Well, thank you so much. I've been asked today to you guys about the current treatment of COVID-19 in adults. Just a brief correction there on the intro. I am not licensed to take care of any pediatric patients. And so I am an infectious disease physician at UMC, and I'm now the medical director for telemedicine services at UMC, which is a new service line that we're starting. Next slide, please. So the objectives of the talk today are to give you an executive summary style presentation of the current state of the pandemic, diagnosis of acute disease, risk stratification for patients diagnosed with COVID, options for outpatient treatment, how to take care of the inpatient with COVID disease that has mild to moderate illness, as well as those that have critical illness. We could talk about COVID for weeks and weeks, not be able to comprehensively hit everything, but we're going to give you a high-level overview with actionable information that you could take to your practice. Next slide, please. So to me, this slide is very striking. If you look at the map of the United States, it is completely red. And this is a reminder to everyone that the pandemic is very much not over. And so every state virtually in a high transmission area. Looking at the right column here, there's data from the Johns Hopkins University tracking website where the United States is #1 in the amount of COVID cases, which is almost 1 million. And then the updated deaths count is actually 650,000 now. Now, I want us just to pause for effect. 650,000 deaths due to COVID in the United States alone in a span of about 2 years. In the Civil War, which is the bloodiest conflict the United States have ever been, 620,000 people died over the span of several years. That's how bad this actually is. Countries that follow us in cases and deaths are India, Iran, the United Kingdom, Brazil, France, Turkey, Malaysia, etc. So we lead the world in case counts, we lead the world in deaths, even though we're a highly developed country and with plenty of resources. Next slide, please. This is a little bit of a busy slide, but just bear with me. This is data from the CDC's COVID Data Tracker. Again, looking at data in the United States, over 39 million infections, which is increased from the last 30 days. The actual death count is now 650,000 cases, and it's increased also over the last 30 days. We're trying our best with vaccinations, with about 74.2% of adults that are eligible for vaccination to have at least 1 dose of the vaccine, but we remain as a country of high transmission of coronavirus infections. In the lower left corner, because I don't know if you could see my cursor, there's a very interesting graph, and the bars have different colors. The orange color represents the Delta variant. So if you look at the first column, which is the end of May 2021, you could see that it's largely blue, and that represented the Alpha variant. In the span of 8 weeks, Delta variant took over coronavirus infections across the United States and really across the world. And this is just a reminder to us that we need to remain humble. We are not smarter or more nimble than nature. Viruses have a job, and their job is to survive, and they survive through replication. And you can only have replication if you have continued infections. On the right side of the slide, there's a state-by-state breakdown of the variants that represent the infection in each state. And of course, the B16172, which is the Delta variant, represents more than 95% of the infections in each state. Next slide, please. So let's talk briefly about diagnosing acute infection. The Delta variant, which originated in India around late 2020, is ravaging the world. It's a highly contagious virus. About 1,000 times more virus are seen in patients with Delta, and now it's objectively considered to be more virulent. The diagnosis should be made with testing, which includes PCR and antigen tests. But notably, these cannot differentiate between wild-type virus and variants. So whole genome sequencing is what the state lab does and many other labs in research settings, and it's done mostly for epidemiologic. So when patients ask, COVID test, Delta, just, statistically speaking, yes, rat. but the test itself can't detect the variants. Antibody test is not recommended for diagnosis of acute disease. And this is important also to tell physicians and diagnosis of acute disease. And the role that it does have is largely for public health reasons. It's important to mention that the clinical syndrome for COVID has changed. To just be cough, anosmia, nausea, vomiting, diarrhea. Now this is found to be less common with Delta. And that's a prodrome that is more of a sore throat that predominates. Testing is really paramount because you just can't make a diagnosis clinically. That just has been, known very well in everybody that's treating COVID. So testing is really paramount because even in post-exposure settings, you can make decisions that are clinical and they're based on a positive test. And you need that test to go one way or the other. A brief comment on vaccines, Dr. Ligon is going to talk about this in detail later, is that breakthrough infections are still relatively uncommon, but they are rising. And this is the effect of the virus learning ways around our roadblocks. They have shown decreased effectiveness against infection, but that was not the primary endpoint of the trials. We have to remember that. And they do preserve effectiveness against severe illness, hospitalizations, and deaths. And that was the primary point, what we're looking for. Next slide, please. So you have a patient with a positive COVID test. How to do risk stratification. On the left-hand side of the slide, multiple risk factors for developing acute and severe disease. And so obesity, older age, heart failure, COPD, high-dose steroids, immunosuppression, you could see that the list is long. And what we have found clinically is that these, definitely are bad omen and increase the risks of you developing severe disease, but we've had plenty of otherwise healthy hosts without significant risk factors develop respiratory failure, cytokine storm, and death. So I encourage you to be as proactive and as aggressive in prevention of infection, as well as in treatment when the patient does have the disease. The disease can have a spectrum that is very varied, and we'll talk about that in the next slide. About 80% of cases are mild infections, 15% of them require hospitalization, and about 5% of them end up in the ICU. And when we talk about mortality, even though it looks that 1% is low as compared to influenza, which is only 0.1%, that is significantly higher with COVID. When you look at geriatric patients above the age of 85, the mortality is up to 27%, and 50% of patients are hypoxic at day 8. So even though the patient's symptoms could be mild at the beginning, they could rapidly progress or have silent hypoxia, which is also a dangerous thing. Next slide, please. So how do we handle the patients that are as outpatients and have a positive COVID test? The treatment is largely supportive. We have readily available O2 monitors that patients can buy on the store or eBay. That they can monitor the oxygen saturations. Looking at vital signs, pulse, and respiratory rate are easy enough for patients to do. If they have a blood pressure cuff, that's also helpful. But I think the most important part is for them to be able to reach a clinician, either in person or via telemedicine, to tell them about signs that are symbols of progression of disease. So what I tell patients usually is, look, this is a highly unpredictable disease. If you get a feeling that something is not right, the best thing you could do is just talk to your doctor. And it's important to do it early because when they have high risks for progression, either because of all of those risk factors that we mentioned in the previous slides, or the clinician's judgment, they should be referred for monoclonal antibody therapy. This is a therapy that can be given to patients that do not yet require hospitalization. In fact, that's part of the EUA, that prevents the development of progression of the disease and prevents hospitalization in about 75 to 80% of cases. So really, it is a marvelous medication to give them. Really well tolerated. The major problem is lack of availability because of the infrastructure needed for hospitals and health systems to deliver the drug. But in patients that have early infection within the first 10 days, that have a high risk of progression as determined by the clinician's thought process, they're eligible and should be referred for monoclonal antibodies. The role of steroids in the outpatient is one of debate. It's not for everyone. Only patients that went to the ED but weren't admitted are supposed to get steroids according to the IDSA guidelines. But then if you look at the studies where that recommendation came from, it's really for patients that require oxygen supplementation to be able to be qualifying for steroids. So it's mostly a supportive care thing. Really, using monoclonal antibodies is a resource that needs to be made more widely available. It'll save lives and it'll prevent hospitalizations. In the South, where patients with COVID are just getting hit really hard and the hospitals are in dire straits, they've really pushed monoclonal antibodies. And I think we could do a little bit better in that as well. Next slide, please. Now, talking about the treatment of hospitalized patients, and those are those that present with mild to moderate or severe disease. The picture on the right is just, a whole bunch of colors with different shades of each color. And that's how I view infection with COVID that is progressing, right? This is not something that is the way we're used to in clinical infectious diseases. You can get a gestalt picture of how the patient is doing, and we're fairly good at predicting if the patient is going to get better or not, despite interventions. And with COVID, I find it incredibly challenging to make that prediction. So patients that require hospitalization usually are short of breath when they come in. They're hypoxic, and that hypoxia is bolded there because it really is a requirement for giving the patient's pharmacologic treatment that we're going to talk about now. They usually have multifocal pneumonia, although if they present early enough, the chest x-rays are not really impressive. But when they come in with hemodynamic instability, that's usually a bad omen. So the standard in treatment is oxygen supplementation for those that require oxygen, prone positioning because that helps improve oxygenation, DVT prophylaxis, this is a prothrombotic disease, and treatment of secondary infections when they are clinically suspected. Notably, the patients that come in with COVID pneumonia usually do have a sepsis syndrome, and because of protocols in hospitals for assessment and treatment of early sepsis, everybody gets antibiotics. For those of us that use procalcitonin judiciously, patients with COVID are noted to have low-level positive procalcitonins, and it doesn't really correlate well with co-infections due to bacteria. So there's plenty of studies out there that show that these patients, at least at the initial hospitalization, don't have bacterial superinfections, and there's a significant overuse of antibiotics. So avoiding antibiotics when possible is a good idea. Let's talk a little bit about drugs used to treat. So remdesivir is an antiviral that has received approval by FDA and authorization for treatment of COVID infection in the United States. Despite some controversy from outside international studies, in the United States, we believe it is good enough to allow its use and recommend its use, especially when given early. Now, early means within 10 days of onset of symptoms. The reason behind that is we have seen through cell culture studies that the viral replication usually stops around day 10. So if you're given an antiviral medication after the point in time where you have active viral replication, it really doesn't add any benefit. And if it doesn't add benefit, then it can only add risk. So early treatment with remdesivir has been found to be helpful. 5 days is the treatment course that is standard in patients that are immunocompromised or that have severe disease. Extending that treatment duration to 10 days is a reasonable thing to do. In those patients that get clinically worse, the suspicion can be most often the development of essentially cytokine storm, which is an overreactive immune response. And I find it ironic because, most people that are hesitant to get vaccinated or that don't believe in COVID say, I want a strong immune system to protect me from COVID. And that's actually what gets you in trouble. So dexamethasone, a steroid, is the standard of care for that. It has shown to have a mortality benefit, and pretty much everybody uses it. Again, the recommendation is in those that require oxygen, and the duration is 7 to 10 days. There's some controversy as to whether you should complete the full 10-day course, but most references say that if the patient's well enough to be discharged, you probably could stop the steroids at that time. The next drug to talk about is the anti-IL-6 blocker, tocilizumab. At the beginning of the pandemic, the initial studies really didn't show any benefit, but most recent studies have shown actually a mortality benefit. So it's now part of the recommendations from the IDSA for treatment of severe COVID that progresses. Sadly, because of the worldwide use of the tocilizumab, it is in a worldwide shortage and it's very difficult to get. In the absence of tocilizumab for patients that do meet that criteria, you could use alternative agents just like JAK2 inhibitors such as baricitinib or anti-IL-1 agents such as anakinra. We're using baricitinib at UMC now because we don't have tocilizumab or have very limited selection of it, and we're seeing some good results with that. Although, again, given early is when you have the best chance to prevent progression, and that's the whole point of giving these medications. Convalescent plasma really showed no benefit despite our willingness to give this therapy to people early on in the pandemic. There's some papers there that say that if you have high titer convalescent plasma, that there is some benefit, but that's just not commercially available, and it's very difficult for labs to actually measure the amount of antibodies in the plasma. So we just really don't use it. When the patients don't get better despite every intervention, which unfortunately those that get critically ill often do get worse in spite of our best efforts, well then they require intubation in places that have ECMO. ECMO is a possibility. Sadly, you know, the mortality in patients that require intubation and ECMO is north of 50%. So early treatment, preventing progression, super important. And use these tools that you have. Always lean on your infectious disease specialist if you have any questions. We're there to help. Next slide. I just took this from the internet to make 2 points. One, we have 3 vaccines available. 2 of them are mRNA technology. One of them is Johnson & Johnson. Highly effective treatment, for prevention. And we should just do everything we can to convince people to do the vaccination. On the right-hand side of the slide, there's 2 different graphs, and that's a comparison in the outcomes of infections and deaths in Connecticut, which is the lower graph, that has heavily pushed for vaccinations, social distancing, mask wearing, etc., and a comparison with Florida, which has not followed those measures. And so it's very clear that data don't lie. Mathematics are what they are, and those are the numbers. So we know what we have to do. We just need to not politicize this and do what we need to do. Next slide, please. Other drugs, just to finish off, a myriad of compounds are being studied for the treatment of COVID-19. Most of them are in stage 2 or stage 3 trials, meaning they're not ready for prime time. The use of ivermectin, hydroxychloroquine, or lopinavir, ritonavir is not recommended for the treatment of COVID-19 unless it is in the context of a clinical trial, which in virtually every instance it is not. So these are recommendations from the IDSA, the NIH, COVID treatment guidelines, the WHO. We took a look at that. They're not very helpful. But they have a collaborative research project to analyze the data on available treatments. And then when they find something that they want to endorse, they will. Next slide. And that's what I got for you today. I'm sorry I went over a couple of minutes. There's so much to say, but thank you for your time and for your invitation.